because we have another wonderful speaker that I'd like to introduce, and another one on Zoom because Andrea lives in Victoria and couldn't be with us today. So let's continue this great conversation as we welcome Dr. Andrea Grindrod from the La Trobe University. And she's going to talk to us today about working with local government, and a great example from Victoria. Andrea is an international leader in public health approaches to palliative care and end-of-life care. Her focus on end-of-life combines research and evaluation, policy and program development, and a system approach to support practice in the local government, disability and neighbourhood sectors. She is the founder and developer of the Healthy End-of-Life program, HELP, which is being used to progress public health palliative care practices and research in Australia and internationally. HELP is featured in the World Health Organisation's Global Atlas of Palliative Care, and Andrea is a member of the PHPC International Council. We're honoured to have you here, Andrea, and thank you.
Good morning, everybody. Can everybody hear me? I'm assuming that I'm on right now, so thank you very much. I'm really excited to be here today. I wish that I could be here, but let's face it, I'm a festive Victorian in lockdown again. But on the upside, it's given me the opportunity to wear my best homemade vintage outfit, so I feel like I'm getting out at least. But I'm also having flashbacks of being zoomed into an aged care facility recently, where within about 5 minutes, most of the audience were asleep. So I can't see you right now, but if you're awake in 5 minutes' time, I'll take that as a really good sign. So we'll get started with that in mind. I'm really excited today to be talking about our local government project in Victoria. And I also know that there's local government people in the audience today, so I'm really excited to share this work. So we're kind of in for a bit of a shift in focus to what we've been experiencing so far this morning. And I'm really looking forward to that. So I'd like to acknowledge the project team who I worked with on this project. Obviously the La Trobe team, myself, Wendy Dager and Bruce Rumbold. The Municipal Association of Victoria was a partnership project, and the lead on implementation, Jan Bruce, Catherine Waziski and Claire Hargraves. And also this project was funded by the Victorian Department of Health, Teresa Williamson and Danny Wong, the project officer. I'd like to acknowledge that I'm presenting our collaborative work on behalf of this team today. A very quick overview on our session outline. I'm going to touch base very briefly on compassionate cities. We heard Alan Kelleher speaking this morning, and this was his book in 2005, and we'll touch on that. Go through the Victorian case study. I'll share the key learnings, touch on the Council's Healthy End-of-Life Partnership Framework, and look at the evidence for the role of local government in this space. This research findings have never been presented before, so it's really exciting to be able to share these. So the first thing that we're talking about is compassionate cities. And this is the book that Alan wrote in 2005. And this book really was his work that considered illness, dying and bereavement within a healthy cities framework from the World Health Organization. It had a really strong community development, health promotion and healthy settings approach in this work. And what he does in this book is consider the contribution of the local government sector and municipal authorities in the contribution to public health palliative care approaches. And of course, consistent with all of Alan's work, it advocates that dying is supported where most people spend most of their time, which is living in the community, in amongst their families and friends. The Victorian case study really is taking the theory of Alan's work and putting it into practice, and seeing what it actually looks like when we start to think about how local government might come to this issue and start thinking about the work. So as I said, it's funded by the state government. This is probably a really important point because it was palliative care funds from the state government normally funding services, but a brave step on their behalf to back public health palliative care, as they have with our unit since 1999, to assign those funds to the local government sector to see what contribution the local government sector could make in improving the end-of-life care outcomes of residents within their municipality. It was done in partnership with the peak body of the local government in Victoria. It included 3 demonstration projects, a rural, metropolitan and regional project that was kind of critical to the learnings and to understand this work. We launched the project through the council ageing portfolio. And the work also included statewide surveys, focus groups, interviews and social network analysis, which I'll get to shortly. But their MAV were really the lead in implementing this work. And we did that specifically because we wanted to work in a sustainable way. We wanted the project to continue beyond our involvement. The project objectives were quite clear. Strategically, we were using capacity building approaches and asset-based approaches. And first of all, we started to look at how do we build organisational capacity in councils to support them to be able to do this work. The second thing that we wanted to do was to use that capacity that was built in councils to support them to build community capacity through their existing structures and networks. And we wanted to make sure that we used evidence-informed public health palliative care strategies when we were working with councils, and we wanted to research the effectiveness of this approach. The findings from our project REACH were very promising. Within the second year, and we haven't actually done the last follow-up survey, but within the second year of the work, 39 Victorian councils out of the total of 79 were involved. That number has since increased. And in councils, we had at least 17 activities and events across the state. We changed about 21 policies and plans in positive ageing strategies and in municipal public health and wellbeing plans. And in the communities, we had 77 external stakeholders engaged with the various councils across the state. So that's 77 organisations that were working with councils in this area. We had 36 councils engaged. We had at least 545 Victorians involved, and that was a couple of years ago now. We know that the work continues. And we had 90 council and community activities that were done externally. And the 17 activities that I mentioned before were ones done inside council organisations. So we have 4 key learnings from this project that I would like to share with you today. First of all, recognising and identifying the role of the local government sector in end of life. And as I said before, this is thinking about how we translate Alan's book, I suppose, in 2005 into practice and test that. The second finding was utilising councils' networks and their partnerships and their expertise to connect the various municipal assets that they have, to understand how councils build community capacity around end of life, and to harness the authority of local government and its proximity to the community to introduce a novel approach to end of life care compared with what the national government brings, for example, to palliative care in Australia, and also by contrast to what state level governments contribute, which is funding palliative care services. And I suppose, if you like, this Victorian case study is an example where the 3 tiers of government or level of government within Australia, federal, state and local, are actively engaged in their contributions toward improving end-of-life care outcomes of Victorians. And what we're very interested in is understanding what the local government sector contributes and supplements to that, what national and state government sector contributes to improving end-of-life care outcomes of Australians. So the first key point that we learned, or the first key learning, was understanding the role of the local government sector. And when we started this project, councils didn't view themselves as having a role in end of life at all. They didn't sort of see it as their core business, and they saw that palliative care was the sector that were responsible for palliative care and end of life care. And we were able to introduce a public health approach to councils to recognise their potential role. And we then supported these councils to explore what that role might look like. And it was very important that we allowed them and supported them to come to this work exploring and understanding their particular contribution. At first they thought that we're not palliative care, so we don't have a role, and we're not clinicians and nurses, so how can we do this work? And we have to really allow that time for them to see the social model of dying and to see how end of life might sit into their existing structures, frameworks, policies and planning. And at the end of the project, the 3 demonstration projects really revealed and clarified the role of councils in this work as community capacity builders, as municipal leaders in public health palliative care approaches, as networkers and connectors of the municipal assets within their region, and facilitators of an integrated end-of-life care system, connecting their health assets with their community assets, and I'll talk a little bit more about that shortly, and facilitators and I suppose advocates of a social model of dying. So local government are often already doing a lot of work in ageing space, disability space, but what we're wanting to do was to support them to incorporate end of life into the existing policy planning and structures and in the work that they already do. And that was really important because the local government sector is very busy and it's always being asked to do more with less, and we needed to make sure that we were supporting them in that work. So the second key finding that we learned was that we were using council's expertise to connect their municipal assets. And so when I talk about assets, I'm referring to all the organisations, people, funding sources, structures, the culture that make up a local government area. There's a lot happening if you took it from a place-based perspective in a local government area. And there's a lot of assets that don't currently contribute to improving end-of-life care outcomes, but could. And so they have direct access into those various entry points within their area. And so that's why we particularly were focusing on an asset-based approach. And so we looked at, their capacity to connect their health assets with the community assets, knowing that both of those are required for optimal end-of-life care outcomes. We knew that they have an important role in supporting the community to understand their role. And they also have the ability to leverage participation from the full range of community resources available to them. And the third key learning was understanding how councils build end-of-life community capacity. And what we learned was really important from the very outset was that, first of all, we needed to build organisational capacity within councils in the first instance. And this actually took quite a bit of time. It was really important for councils to come to this work in their own time, in their own pace, and acknowledging their own resources. And it wasn't until we could build the capacity in councils around this topic and they were comfortable with it and developed their own language around it and could see their particular role in this work that they then were able to start to work with their communities. And that was really important. So taking that time to have those internal conversations within council really helped to then move the work outside of the council environment. We drew upon their existing relationship with communities. One demonstration project, for example, had 80 cold ageing care groups for culturally and linguistically diverse communities. So they were already working with the ageing community through their ageing platforms. So they had those connections in place. We were interested in just incorporating end of life into that work. And we were interested in, we identified and leveraging their community assets. And they also engaged their community leaders. Was another way in which they built community assets and community capacity. We drew upon their community development expertise. We acknowledged the diversity of the councils and the diversity of their communities, that it will look different in each place for different reasons. And we utilised their local knowledge of their communities to tailor the activities. And that's because local government will know exactly who's in their municipality, who are disadvantaged, what are the ageing profiles, and so they very much have that local wisdom and that local knowledge of their communities to support them. And this is a really important point when thinking about end-of-life care. And they also became very strong advocates of reorienting the community norms around caring at end of life towards a social dimension of dying. So they were able to bring that message of public health palliative care to their communities and all their existing assets. And the fourth key finding was that local government uniquely has the authority and to leverage and to bring together their assets and their stakeholders, and also are the closest level of government to their community. So a local government or a council has the authority to engage their formal municipal stakeholders such as hospitals and health services and primary health networks, for example. They have the ability to bring those together because of their authority and their position. They have the proximity, though, unlike state and national council or levels of government, to engage grassroots community. So they're infiltrated all through community networks, which is very valuable to public health palliative care approaches. And their municipal planning processes, which is what I was talking about before, understanding through ABS data and information and community focus groups and doing local needs analysis. They understand what's happening in their local area, and that can guide their activities based on the demographic need. They're also very effective in using place-based approaches to leveraging local participation. And by incorporating the third tier of government in Australia into end-of-life care, incorporates and brings a new dimension and a novel way of thinking about end-of-life care that doesn't currently exist within a formal government structure, which I think is incredibly important. So what did some of the staff say when they were working in this project? This is some of the data that we collected and some of the from the focus groups. And so council sort of described their role, typical kind of comments such as these. We'd never thought about end of life either personally or professionally before. It's a massive learning. I see relevance and opportunities now constantly. And when I tabled the implementation plan, there was no question of why we were able to do this. Straight away, we could see that we were empowering our community, and this was wonderful. The next slide. Councils really respond to their role around community and social cohesion and making sure people that are disadvantaged are not left behind. And this is where their diversity role in the local government area is really important. They can see that end of life was a gap, something that was missing, and no one else had this role. And when we had council staff saying there's a real role for local government, definitely for our department. Death is part of life and it has implications of how we live our life. And this is good because we were able to start seeing that they were bringing their expertise into this area and that they were pursuing the public health palliative care approach. And I'm just finishing up now, but it won't be too much longer. I know that I've got a warning on my time. So now we're looking at the council's health end-of-life partnerships, and what we sort of saw with councils, and this is what we examined in one of our demonstration projects, is how council is a linking asset. They have the capacity and the capability to bring their community networks together with their health networks and explore that. And if I have permission to nerd out for the last minute or so of the presentation, I'd just like to show you the data that we collected at Mansfield Council Shire. So at the beginning of the demonstration project, this was the first network that we took, a social network analysis where the dots are people or actors in the network and the lines are the relationship. And you can see that in this network, the dots, the network's not very dense, there's not very many links, and they're not very well connected. At the second point of the study, you can see councils in here, which is the yellow, the green centre dot, was much more connected. The network is growing, there's more relationships happening, you can see more of health coming in, but you see much more community and individuals compared with the first one, which had less community networks. And by the end of the project, this is the kind of network that we were able to capture. You can see councils in the centre who are very connected with both health, community and individuals. The network is growing, it's dense, there's lots of connections. And when you think about Alan's work on compassionate communities, or this is what I would say is a collaborative community where we can actually measure what compassion might look like and what the connections are between people. And this shows that how the role of councils in terms of their centrality of being able to bring together both health and community groups from integrated end-of-life care system. So what can we say about the role of governance? Well, the evidence tells us that local government has a very distinct but valuable role in end-of-life and bereavement care for citizens living and dying in their municipalities, that the Compassionate Cities work that Alan Kelleher wrote up actually works. Thank you.
Thank you so much, Andrea. Time. We're out of time. We're all over the place now, which is really interesting in this conversation that we're having today.